Part 4 of Chapter 4, Part D of Chapter 4, whatever you want to call it. We're getting into the nitty-gritty of ARDS. So let's talk about the right ventricle first. This portion of Chapter 4, I'm just going to talk about mechanical ventilation of ARDS. I'm not going to get into the physiology of spontaneous respiration with ARDS, because some of it just simply recapitulates the physiology that we talked about with left heart failure. So I want to talk about mechanical ventilation. Most patients with ARDS are mechanically ventilated anyway, so it makes sense to focus on that physiology. And I wanted to address some conflicting results about the effect of PEEP and positive pressure on right ventricular size and function in ARDS. Some of them showed that the RV dilates, some of them show the RV shrinks. So, how can we reconcile some of these differences? And I think that some of the physiology we've already talked about really in chapters 3 and 4 can help explain some of these differing opinions. But first, I think it's important to understand this distinction that Luciano Gattinoni and colleagues proposed in the late 90s between pulmonary ARDS and extrapulmonary ARDS. And I talk a little bit about this in my introduction to chapters 3-4. But in both states, pulmonary and extrapulmonary ARDS, there's a drastic reduction in the compliance of the respiratory system, that is the lungs and chest wall together, and that leads to high peak and high plateau pressures. But the key distinction is that in pulmonary ARDS, the abnormality is impaired pulmonary compliance. The application of pressure to the proximal trachea that you do with mechanical ventilation leads to a large increase in the transpulmonary pressure, as little of the airway pressure is transmitted to the pleural space. Okay, that's a key distinction. While lung volume, well, I shouldn't say while lung volume will not change greatly. If these patients are on volume-limited mechanical ventilation, as they really should be, because that's what the ARDSNet trial used, the volume will be constant, but there will be an elevation in the transpulmonary pressure, and it is the increase in transpulmonary pressure that augments right ventricular afterload. And remember, we talked about what determines pulmonary vascular resistance. So RV afterload is a summation of the radius of curvature of the RV and the transmural pressure of the RV free wall. And the transmural pressure is determined largely by the impedance of the pulmonary arterial tree, which in turn is largely determined by pulmonary vascular resistance. And as the distending pressure of the lung, that is the alveolar pressure less the pleural pressure or the transpulmonary pressure, supersedes the pressure within your pulmonary blood vessels, well, then those blood vessels will collapse. The total cross-sectional area of the pulmonary vascular tree will be diminished. Pulmonary vascular resistance is therefore increased, and so will our right ventricular afterload. Clear? By contrast, Gattinoni and colleagues described extrapulmonary ARDS, and this resulted in very low chest wall compliance. So, like pulmonary ARDS, this leads to a poor respiratory system compliance. Remember, as I've shown in a number of slides already with the modified Campbell diagram, the respiratory system compliance is determined by the summation of the compliances of the lungs and chest wall together. So you could have a reduction in either, and you'd reduce the respiratory system compliance. But the important thing is that changes in pulmonary compliance versus changes in chest wall compliance, while they will sum to potentially give the same reduction in respiratory system compliance, will have very different hemodynamic effects. The reduction in chest wall compliance results in an increase in pleural pressure or intrathoracic pressure. So that's different from transpulmonary pressure. This tends to augment the pressure around the heart or juxtacardiac pressure, and therefore it promotes more of a preload effect on the RV. It therefore reduces the RV transmural pressure and would tend to shrink the RV, whereas an increase in afterload would tend to cause the RV to distend with insufflation of the lungs by a mechanical ventilator. So what is the underlying difference between pulmonary and extrapulmonary ARDS? Well, he gets into it in the paper, but pulmonary ARDS is more of a direct toxic insult to the lung, like a bad aspiration or a bad pneumonia that's caused a profound inflammatory response in the lungs leading to ARDS. Whereas extrapulmonary ARDS is usually the result of intra-abdominal sepsis, trauma, pancreatitis, profound inflammatory insults that are occurring outside of the lung. The extrapulmonary ARDS, while it was typically characterized by atelectasis that was recruitable and pulmonary edema and intra-abdominal pressure, whereas pulmonary ARDS was more consolidation and lung physiology that was not readily recruitable. So this is my silly little diagram of the balloon in a box, and I use this in a few different lectures, but I think it kind of gives a pictorial representation of this difference between pulmonary and extrapulmonary ARDS, or how intrathoracic pressure is determined by the lung pressing out against the chest wall. So this is your volume limited ventilator. So to all three of these patients, they're getting the exact same volume. This is the normal patient. Normal pulmonary compliance is the balloon. Normal chest wall compliance is the box. This is the patient with extrapulmonary ARDS, or a diminished chest wall compliance from any cause, massive ascites, massive obesity, abdominal compartment syndrome, you name it. And that's highlighted by this kind of thick, chunky looking thoracic box here, okay, low chest wall compliance. And then this is the pulmonary ARDS patient. This is the patient with the bad pneumonia, the bad aspiration, you name it. Lung compliance is diminished, chest wall compliance is the same. So I'm going to give all three of these the same volume breath. So we'll watch what happens to the normal. This is the control. The lung will inflate and the thorax will inflate together. The intrathoracic pressure, or pleural pressure, is the pressure that's generated between the balloon and the box. And the transpulmonary pressure is the pressure gradient that's between the inside of the balloon and the intrathoracic pressure. Now watch the patient with the extrapulmonary ARDS, or the poor chest wall compliance. Well, they're going to get the same volume, so the lungs are going to expand, but they're going to push out against this poorly compliant chest wall, and therefore you can imagine that the pressure between them, the intrathoracic pressure or pleural pressure, will be increased to a great extent compared to here, even though they're getting the same volume. Now, that's the low chest wall. Now let's talk about the pulmonary compliance, or the pulmonary ARDS, or the low pulmonary compliance. Well, it's getting the same volume, so this balloon is really maybe I should have animated it increasing to the same volume. But what happens is, as you can see, the pressure within the alveolus, or the lung, relative to the intrathoracic pressure is greatly increased. So it increases this transpulmonary pressure, which, it's kind of ingrained into all of our skulls during rounds in the intensive care unit, that this is going to increase barotrauma and put you at risk for, alveolar rupture and pneumomediastinum and pneumothorax and, all these different terrible physiologies that can occur. But it's also after loading the right ventricle. Remember, as the transpulmonary pressure is increasing to this great extent, the RV is just squeezing its brains out, and it's just pumping against a brick wall. So don't forget about the hemodynamics of increased transpulmonary pressure as well. So in this patient, you're going to have the pressure in this tube is going to be very high, and it's driven by the poor chest wall compliance, and you'll have a very high intrathoracic pressure. Not very high, but relatively high intrathoracic pressure. This too will have a high driving pressure, so the pressure in this tube will be high, but the transpulmonary pressure will be high, and the intrathoracic pressure will not be as high. Preload effect, afterload effect. That's what you should take out of this cartoon. So now I'm just going to graphically represent through the modified Campbell analysis what I just illustrated to you in terms of that cartoon. So this is pulmonary ARDS. I think you can probably get a sense of what's going to happen here. Remember, this is your pulmonary compliance, this is your chest wall compliance, and this is your respiratory system compliance. So in the setting of pulmonary ARDS, there's a significant decrease in your pulmonary compliance. So the pulmonary compliance curve shifts down to the left, your functional residual capacity is diminished, and now for any given lung volume, there's a greater pressure differential, so a greater pressure must be applied by the ventilator to affect that volume change. So you can see here, by graphing out each of these pressure differentials versus a volume, so for each for each volume, the pressure differential between the pulmonary compliance and chest wall compliance curve, the difference between them defines the amount of tracheal pressure that must be applied by the ventilator. So it's increased. If you were then to graph that in terms of the airway pressure and your respiratory system compliance curve, well, the respiratory system compliance is shifted down and to the right, so its compliance is poor. That means there's a higher airway pressure. Modified Campbell diagram, remember, it's pleural pressure when you're talking about these curves together, and it's airway pressure when you're talking about the respiratory system compliance curve. You see that there will be higher airway pressures to achieve a given volume, and that's essentially higher plateau pressures, as we all know occurs when pulmonary compliance is diminished. So your plateau pressures for a given volume will be high, but because the chest wall compliance has not changed, assuming it hasn't changed, there will actually be no change in your intrathoracic or pleural pressure. But because this is your plateau pressure and end inspiratory hold pressure, it's assumed that that roughly approximates your alveolar pressure, because it will create a static column of air from your trachea all the way down to your little alveoli. Well, your alveolar pressure less your pleural pressure becomes your transpulmonary pressure. So the lateral distance between the static pressure volume relationship of the respiratory system, that is a plateau pressure at a given volume, the lateral distance between that curve and your chest wall compliance curve, that becomes an estimate of your transpulmonary pressure, which, as I've talked about, determines your right ventricular afterload. In this situation, the decrease in your respiratory system compliance, that is the higher your alveolar pressure, is being driven by the decrease in pulmonary compliance. Chest wall compliance is staying the same, so transpulmonary pressure, right ventricular afterload pressure, is augmented. In pulmonary ARDS, there's also an increase in airways resistance, so your peaks may go up as well. Okay? Extra-pulmonary ARDS. So this is a significant change in your chest wall compliance. So see that again, chest wall compliance here. This is the normal patient. Pulmonary compliance, functional residual capacity, chest wall compliance here. Modified Campbell diagram. This is pleural pressure or intrathoracic pressure when referring to these curves. It's airway pressure when referring to the respiratory system compliance curve. There's a decrease in chest wall compliance. Your functional residual capacity drops, okay? Now there's an increase in pressure that must be generated for each given volume, but this is being driven by the drop in chest wall compliance. So the compliance curve of the respiratory system is decreased, but now look, your transpulmonary pressure is diminished, but your intrathoracic or pleural pressure is increased. So here's your plateau pressure you get at the end of an end inspiratory hold, and that's your pleural pressure that you would get if you were using an esophageal balloon pressure monitor as an estimate of your pleural pressure. So you can see your transpulmonary pressure is much diminished. So this, as you can assume, will render more of a preload effect upon your right ventricle and less of an afterload effect. Okay, so this is pulmonary ARDS and the right ventricle during mechanical ventilations. Remember, pulmonary ARDS, I've not depicted it here, but it's a diminished lung or pulmonary compliance curve. The chest wall compliance curve has remained unchanged, and then the respiratory system compliance curve is shifted down and to the right as a result of the not depicted diminished pulmonary compliance. Again, modified Campbell diagram, it's the pleural pressure or airway pressure when dealing with this curve. This is atmospheric pressure, this is above atmosphere, this is below atmosphere, and then this is lung volume on the z-axis going into the page. And again, I've omitted the pulmonary compliance curve. So let's go through the thought experiment. What happens when you apply PEEP? Well, the PEEP increases your lung volume. The lungs press out against the chest wall. The chest wall the compression of the two together increases your intrathoracic pressure from here to here on the x-axis. So your pleural pressure is increased along your chest wall compliance curve. So the large reduction in respiratory system compliance is due to the poor lung compliance. Therefore, the pleural pressure is increased, but not to the same extent as the airway pressure. So at the end of the application of PEEP here, lung volume is increased from here to here. Therefore, your airway pressure or your static plateau pressure will have increased from here up to here at the end after you've applied PEEP. So you can see there's a a large increase in your transpulmonary pressure with the application of PEEP to this patient. If you then apply a breath on top of the PEEP, well, your intrathoracic pressure is going to go from here to here. Your airway pressure is going to go all the way from here out to, I haven't even graphed it here because it's so far out, but you could imagine that your transpulmonary pressure at the end of a breath on top of the PEEP is going to be quite high in this patient with poor pulmonary compliance. Okay, so now let's superimpose that on the Guyton analysis. Again, we've been through this already. This is your systemic venous return curve. This is your right ventricular cardiac function curve. This is your measured CVP, or right atrial pressure here. And then this is the distending pressure, which is the pressure within the vessel less the pressure outside the vessel. The pressure outside the vessel tracks your intrathoracic pressure along the Campbell analysis into the page. Your right ventricular cardiac function curve is shifted down to the right in this patient. I've done that as a function of, maybe this patient is septic and has a septic cardiomyopathy. Their right ventricular afterload is high from hypoxemia and high transpulmonary pressures. So this curve is going to shift down and to the right and therefore increase descending pressure. Well, now let's intubate this patient and immediately apply some PEEP. Okay, so it's going to alter systemic venous return as the abdomen is pressurized. And it's also going to affect the position of the right ventricular cardiac function curve and its slope. So it's going to shift rightward as a function of the small increase in intrathoracic pressure, but it's going to shift down and to the right. Watch the curve. It will shift down and to the right as you increase the transpulmonary pressure at the end of the application of PEEP. So this induces a steady state reduction, because PEEP is a steady state thing. It's present for every breath. This is going to impose a steady state reduction in your right ventricular output, a steady state increase in your measured right atrial pressure, and a steady state increase in your right atrial distending pressure. So with the application of PEEP in this patient, you may actually see, or you would expect to see, an increase in your right ventricular dimensions. That will be exacerbated or worsened, quote unquote, by pressurization of the abdomen, so the venous return curve is shifted rightwards, and so that would tend to facilitate volume loading of the right heart and therefore facilitate distension of the RV. Now again, this will be determined by the patient's underlying volume status and the amount of PEEP that is applied. So now when you add an intermittent positive pressure breath on top of the PEEP, you shift the curve rightwards even more, and you may actually result in a significant downshift of the right ventricular cardiac function curve as a result of the very high transpulmonary pressure, which I have not depicted here because it just shoots off the page. So this will result in a higher pressure, a lower output because you're transiently increasing right ventricular afterload as a result of the high transpulmonary pressure, and even further distension of the RV. So in this patient, you're going to have a steady state decrease in cardiac output as a result of the PEEP and the high transpulmonary pressure, and then you'll have phasic intermittent breaths, which are distending the RV and lowering its output with each breath. And going back to Chapter 8 and talking about the physiology of pulse pressure variation, that in this patient who may be volume non-responsive, and in fact we want to typically keep patients with ARDS on the drier side, this patient may actually have pulse pressure variation, not as a function of being preload responsive, but as a function of just changing afterload with each breath. And you may get a false positive pulse pressure variation. And indeed, it's been found that patients with severe reductions in pulmonary or severe reductions in respiratory system compliance on the order of less than 30, I think was the number quoted. These patients can have a diminished specificity in pulse pressure variation when in this state. Okay, so similar physiology, but now let's just run through the same application of PEEP and then the application of a breath on top of the PEEP, and let's see how that affects the left ventricle. Well, we've already talked about applying PEEP increases your intrathoracic pressure along the pulmonary the chest wall compliance curve from here to here. So your intrathoracic pressure increases along the x-axis. The x-axis is pressure in centimeters of water, pleural pressure with respect to this curve, airway pressure with respect to the respiratory system compliance curve. And remember, the respiratory system compliance curve is shifted down and to the right, and it's because of a shift down and to the left of the pulmonary compliance curve, which I've not depicted here. This results in a high transpulmonary pressure and a high steady state increase in your right ventricular afterload, as depicted there. When you then apply a breath on top of that, well, then your airway pressure goes way up, your transpulmonary pressure goes way up intermittently, above and beyond the increase in transpulmonary pressure that you have from the application of PEEP. So now let's rerun that through that thought experiment with the Guyton analysis superimposed. Now, Guyton analysis, again, blood flow on the y-axis. This is now left atrial pressure in millimeters of mercury on the x-axis. This is atmospheric pressure is 0. This would be essentially your wedge pressure, your pulmonary artery occlusion pressure, left atrial pressure here. And this would be intrathoracic pressure. Pulmonary. Now this is the pulmonary venous return curve. And again, as I've mentioned multiple times already, I do not depict it, but with an increase in intrathoracic pressure, the pulmonary venous return curve and the left ventricular cardiac function curve will shift rightward with the increase in intrathoracic pressure in tandem, but it will not per se, the increase in intrathoracic pressure alone per se will not change the distending or transmural pressure of the left atrium or the left ventricle and diastole, because both the pulmonary veins and the left ventricle will be affected by the increase in intrathoracic pressure equally. Nevertheless, changes in intrathoracic pressure can change the diastolic and systolic properties of the LV and also the pressure head for pulmonary venous return, so it can shift the curves relative to each other by that manner. So the application of PEEP by the ventilator again shifts the right ventricular cardiac function curve rightward. That tends to increase the afterload of the RV because of the increased transpulmonary pressure and therefore cause the RV to dilate. Well, what does that do to the left ventricular cardiac function curve? Well, the dilation of the RV tends to shift the LV function curve down and to the right because of ventricular interdependence effects, and that would be a steady state effect. Further, this would tend to decrease the capacitance of the pulmonary vascular bed, which would tend to augment the pulmonary venous return curve to the right, which would tend to, it will kind of be of a mixed effect with increased venous return, but also somewhat impaired cardiac function depending on the degree of RV dilation with the application of PEEP and the steady state increase in the right ventricular afterload. And then with the breath on top of it, your airway pressure is going to go up, your pleural pressure will increase, your right ventricular distending pressure will go way up. Remember, this is the ghost of the RV curve here. Pulmonary venous return will shift to the right even more, and your left ventricular cardiac function curve will shift downwards. So going through that one more time, applying the breath on top of PEEP, you can watch the LV cardiac function curve shifts down and to the right. Venous return increases, which tends to defend LV output, but the shift in LV compliance, or the decrement in LV compliance, can be quite profound depending on the degree of RV distension. Now, to the extent that intrathoracic pressure increases and mitigates left ventricular afterload, you may counteract some of that effect, but it's hard to know. In patients with underlying normal LV, as I've illustrated in this graphic, the afterload effects would tend to be less pronounced, and it would be more of this diastolic ventricular interdependence effects. Then on expiration, with expiration, the RV tends to dilate with, the RV dilates with inspiration when the right ventricular afterload is high. With expiration, the RV tends to shrink in cavity size, and that may release some of that negative diastolic interdependence effects on the LV. But I've illustrated it here that, this is a few cardiac cycles later with the steady state effects of the PEEP diminishing right ventricular output. again, after a few cardiac cycles, as this is established, your pulmonary venous return curve will shrink and shift to the left, and you may have a diminished left ventricular output as a steady state effect. So that would be on expiration, your left ventricular cardiac function curve may shift up and to the left a little bit as diastolic effects are removed, but you may have this diminished preload effect that is essentially a delayed series effect of diminished right ventricular output that came with the positive pressure breath. Remember, with inspiration, with high RV afterload, you can temporarily diminish RV output, and then a few cardiac cycles later, that would be reflected in diminished pulmonary venous return. So you may actually have diminished LV output, not as a function of decreased RV, right ventricular preload, but as a function actually of increased right ventricular afterload that is diminishing its forward flow, and therefore in turn diminishing LV output. So again, this can be an explanatory factor why you can get pulse pressure variation in patients with very poor respiratory system compliance, even if these patients are not volume responsive. You may get pulse pressure variation, but it's not a function of preload responsiveness of the RV. It's more a function of increased right ventricular afterload effects. So the same thought experiment now with ventilation in again, these patients are depicted as being heavily sedated and maybe paralyzed because the chest wall compliance curve is not shifting at all. The muscles of inspiration are completely negated here. So now in this patient, you can see the respiratory system compliance curve is shifted way down into the right, but it's being driven by this diminished chest wall compliance, because this chest wall compliance curve is shifted way down into the right. This is an example of extra-pulmonary ARDS. This is the stiff box example that I gave to you a few slides ago. Again, it's a modified Campbell analysis. So on the x-axis, you have pleural pressure or airway pressure in centimeters of water. It's airway pressure in reference to the respiratory system compliance curve, because this is the pressure that you're measuring off of the ventilator. And it's pleural pressure when considering the chest wall compliance curve, because this is the pressure volume relationship that the pleural pressure assumes when the patient is passive with the ventilator. So if you were to take this patient and apply PEEP, there would be a greater increase in intrathoracic pressure because of the diminished chest wall compliance. So it would cause, as we'll see, a greater rightward shift of the right ventricular cardiac function curve. And with applying a breath on top of PEEP, well, you increase your intrathoracic pressure to a greater extent with that intermittent breath. You'll increase your airway pressure as a function of airways resistance here and respiratory system compliance, but you can see that the transpulmonary pressure, that is your end inspiratory alveolar pressure, compared to your intrathoracic pressure, is quite diminished. And that's because the chest wall is very stiff and intrathoracic pressure is now quite high. So that transpulmonary pressure is quite low, and therefore the right ventricular afterload is quite low relatively. And even with the application of PEEP, there's a steady state increase in intrathoracic pressure and a steady state, not terribly profound increase in right ventricular afterload. So now let's see what that looks like with the superimposed Guyton analysis. Well, now we have on the x-axis right atrial pressure in millimeters of mercury. This is your CVP, or right atrial pressure as measured by a triple lumen. Here, this is your systemic venous return curve. This is your cardiac or right ventricular output. Okay, and now we're going to apply that PEEP from there to there. So you have a much greater rightward shift of your right ventricular cardiac function curve, and that's because there's a greater increase in intrathoracic pressure, and it's going to shift along the pressure curve to that extent. Similarly, there's less here. I don't have it depicted here, but this is a steady state effect because PEEP is present with each breath. Similarly, the transpulmonary pressure is not very great, so the right ventricular afterload is not really augmented all that much. So the slope of the RV cardiac function curve is not really impaired all that much. And then as you apply a breath on top of that, again, sorry, just stepping back one moment, PEEP also results in a steady state change in your venous return characteristics. It tends to increase your mean systemic filling pressure and at the same time decrease the maximal venous flow, and that's because as the lung volume is increased and intrathoracic pressure is increased and abdominal pressure is increased, that facilitates collapse of the great vein and therefore diminishes your maximal venous return. So now we're going to apply a breath on top, and again, the right ventricular cardiac function curve doesn't shift down and to the right because there's a minimal increase in your transpulmonary pressure here because of the increase in intrathoracic pressure. The increase in intrathoracic pressure, though, does shift the right ventricular cardiac function curve rightward to a greater extent, and therefore diminishes the transmural pressure of the right ventricle, which would tend to shrink its cavity size. You will have a decrease. You may have a decrease in your cardiac output, but not to the same extent. And again, I have not illustrated it here, but that breath on top of PEEP would tend to shift your venous return curve transiently to the right as well, which would tend to defend cardiac output. And I just honestly just ran out of room here, so I didn't animate it. But again, that's a transient effect, that breath on top of the PEEP. And then running through the same physiology for the left ventricle, PEEP increases your intrathoracic pressure along the chest wall compliance curve, and then it increases your intrathoracic pressure with the breath on top of PEEP, and your airway pressure also increases as a function of airways resistance and respiratory system compliance. But this transpulmonary pressure, again, this is more of an effect on the right ventricle, is minimal. So running through that again, now on the x-axis, this is atmospheric pressure, this is left atrial pressure, left atrial distending pressure. Again, the absolute values are not as important here because, as I've mentioned, as intrathoracic pressure increases and decreases, the pulmonary venous return curve and left ventricular cardiac function curve shift together in tandem, but they can still shift relative to each other based on changes in left ventricular compliance, afterload for the LV, and pulmonary venous return. So we're going to see the ghost of the RV change. This is the ghost of the RV here. The application of PEEP will shift the right ventricular cardiac function curve rightward, cause the RV cardiac function, or cause the right ventricle to shrink in size. And what does that do to the LV? Well, it probably has minimal effects on the left ventricular cardiac function curve if it's a normal LV curve and the RV is not all that distended to begin with. But the increase in PEEP will tend to augment, or the application of PEEP will transiently augment pulmonary venous return and therefore increase flow to a certain extent. And then a breath on top will then further increase pulmonary venous return to this preserved LV cardiac function curve. Again, it's not really shifting up and down to the left because, as intrathoracic, you could say, well, as intrathoracic pressure is increasing, it would tend to decrease the afterload. But if this person has normal cardiac function to begin with, the afterload effects will not be that profound. And similarly, while it will shrink the right ventricular cavity size, unless the RV is heavily dilated, it's not really going to improve the diastolic characteristics of the LV all that much. And then on expiration, what you will see a few cardiac cycles after the initiation of mechanical ventilation is that your pulmonary venous return will diminish as a function of the steady state decrease in your right ventricular output. So that was it for part D of Chapter 4. And we'll move on to this final part, which is cirrhotic endotoxemia. And I've chosen this clinical scenario because it kind of combines a little bit of everything. It combines, in cirrhosis you have impaired chest wall compliance from ascites. You often have increased lung water, so you have impaired pulmonary compliance. The effects of sepsis on systemic venous return will illustrate here, and it'll kind of all come together in one clinical scenario that will kind of highlight a lot of the physiology that we've already talked about. Thanks.